This video demonstrates the hardware removal of medial tibial plate to buttress plate in 35-year-old female, 2 years post-operatively presented with a soft tissue irritation. A pre-operative AP and lateral radiograph confirms fully united proximal tibia fracture. The construct consists of medial buttress plate with 3 distal cortical screws and 2 proximal cancellous screws. We place the patient supine with tourniquet inflated and extremity routinely prepared and draped. A skin incision is made directly over the previous surgical scar along the medial border of proximal tibia. Go through subcutaneous tissue in the same line as skin incision. As we dissect through the skin and subcutaneous layer, a full thickness flap are elevated on both sides. Care is taken to protect saphenous nerve and vein, which is typically posterior to this surgical line. And at the middle of our incision, there lies a pes anserinus tendon. Our primary objective throughout the dissection is to preserve the insertion of pes and obtain the clear exposure of the implant. To safeguard the pes anserinus, we begin deep dissection distally, where the plate and cortical screw are easily palpable. A deep sharp dissection and electrocautery are utilized directly over the bone to detach the soft tissue and periosteal adhesions from the plate surface and screw heads. Working distally first give us a clear plane before advancing towards the tendinous insertion. Moving proximally, a deep fascia is incised, staying proximal from the pes tendons. Using periosteal elevator and electrocautery, we detach the soft tissue covering the proximal buttress plate and proximal plate edges. All 5 screw heads are meticulously cleaned off of the fibrous outgrowth to ensure seamless driver engagement and prevent slippage. We begin screw removal proximally. Standard technique is applied. Fully seat the driver, apply firm downward axial pressure and back out the screw to prevent head slippage. The proximal cancellous screws are removed first, followed by the distal cortical screws. Passing the chisel in between the cortex and plate make the plate free. After all screws are out, remaining soft tissue attachment beneath the pes tendon are gently released. We first use the periosteal elevator and a cautery, allowing the plate to safely extracted proximally while preserving the tendon integrity. Here you can see how we detach the adhesion under the pes anserinus along with preserving its insertion. The tourniquet is released to verify hemostasis, followed by a copious irrigation. Screw holes are lightly tapped to clean the fibrous debris and stimulate cancellous bone healing. A bone nibbler is used to smoothen the bone overgrowth and reactive soft tissue formations that might be a cause of post-operative irritation. A layered closure is done. We first reapproximate the deep fascia using number 1 bicryl in an interrupted fashion first. Soft cutaneous tissue is closed by a 2-0 bicryl. And for the skin, a vertical mattress suture are preferred to ensure precise tension-free edge eversion and optimal scar healing. And finally, a sterile compression dressing is applied. I hope you gained something from this surgical demonstration. Please do subscribe for similar more videos. Thank you.